Welcome everyone to Grand Rounds this morning. Before introducing our speaker, I just wanted to make a couple announcements. First, I hope that our move from WebEx to Zoom has been helpful to everyone in navigating the online systems. But if you're having any problems, please let us know. Second, our speaker for next week is Marina Picciotto, who is the editor-in-chief of the Journal of Neuroscience, and she will be presenting on cholinergic mechanisms and stress-related behaviors relevant to depression. And then the week after that, we have Damien Fair coming to present on some of his fMRI research. We try very hard to get high-quality speakers, but Damien, as some of you may know, was just awarded the MacArthur Genius Award. So it's nice to have a certified genius presenting to us in a couple weeks. But for today, we are extremely excited and grateful to Vikram Patel to come and present to us. Dr. Patel has a very esteemed background, and I will try to cover some of the highlights, but I'm sure I'm missing many of his incredible accomplishments. So Dr. Patel is the Pershing Square Professor of Global Health and Wellcome Trust Principal Research Fellow at Harvard Medical School. He co-leads the Global Mental Health at Harvard initiative. His work is focused on the burden of mental health problems, their association with social disadvantage, and the use of community resources for prevention and treatment. Dr. Patel is a co-founder of the Movement for Global Mental Health, the Center for Global Mental Health at the London School of Hygiene and Tropical Medicine, the Mental Health Initiatives Network, and Sangath, an NGO in India, which won the WHO Public Health Champion of India Prize. Dr. Patel is also a fellow at the UK's Academy of Medical Sciences and has served on the committee which drafted India's first National Mental Health Policy and the WHO High-Level Independent Commission for NCDs. Dr. Patel has been the recipient of multiple awards, just to name a few: the Chalmers Medal, the Sarnet Prize, the Pardes Humanitarian Prize, and the John Dirk Canada Gardner Award in Global Health. He's also been listed in Time magazine as one of the 100 most influential persons in the year 2015. So with that, I will turn it over to Dr. Patel, and thank you so much for presenting to us.
Thank you very much, Jonathan, and thank you for the invitation to present on this grand round. It's a shame that I can't be with all of you in person, but I hope that I'll infect you with some of my enthusiasm about reimagining mental health by learning from the Global South on how we could actually improve the quality and access to mental health care here back home in the US. Let me first put my slideshow on. Can Jonathan just confirm that you can see my slides clearly?
Yes, they look great.
All right, great, excellent. So the title of my talk is deliberately and provocatively titled "Transforming," because I think, as you will see as I proceed with my talk, that simply doing more of the usual, in my view, is not going to be able to address not only the current burden of mental health problems that this country has faced, but also the burden of mental health problems that are going to be sweeping our communities in the months and years ahead. This is my disclosure slide. So let me first start by looking back in time to when I began to research mental health problems in places where there were very few mental health professionals and where the social and cultural contexts were completely different from where most psychiatry and psychology was being practiced, which was to a large extent in Europe, in North America, and in some affluent parts of the low and middle income world that we used to call the developing world. So this is the sort of stuff I would encounter. I call them myths now, but they were really assumptions and beliefs even at the time when I started 25 years ago, first in Zimbabwe and then in India. One of the most common assumptions was that mental health problems were so completely culturally constructed that they were in effect all of the descriptions in psychiatry and psychology were in effect cultural constructions of a Caucasian or Western. Western was really a euphemism for white or Caucasian populations. So it didn't really apply in any meaningful way to the rest of the world. Another and completely different kind of assumption was that actually mental health problems were some kind of higher order aspiration for people, and those who were poor and poor countries more generally, for them this was a luxury item because more basic necessities to do with food, shelter, and physical health always took precedence over mental health. There was a sense that mental health was a concern of the worried well, as opposed to people with really much more pressing real world problems. And in those particular populations, it was really another major question was really, how do you separate mental illnesses from social suffering? The kind of suffering that comes with the miseries, the daily grind of a poor life, a life that has been imbued with disadvantage and deprivation from the very beginning. How do you actually separate that kind of misery of everyday life from mental illness? It was almost as if, as a corollary to the worried well, that only the wealthy really could have the right to have a mental health problem because there was no obvious social circumstance that could explain why they had that problem in the first place. There was also the idea that mental health problems were not really serious in the same kind of way that physical health problems were, because principally you couldn't actually see them, you couldn't measure them, and of course they didn't seem to kill people in the kind of way that, say, HIV, TB, maternal health conditions, and others would kill people. And this was a very common reason why, for example, all of these were actually very common reasons why development agencies, global agencies would systematically underfund and ignore mental health altogether. And then even if you could address all of these other questions, these other myths, and even if science showed that they were all untrue, there was also then the other challenge, which is that it appeared that mental health problems were so darn complicated to manage that you needed a psychoanalyst spending years and years with someone on a couch 3 days a week, spending thousands of dollars a year with uncertain benefits. And so this was completely not scalable or translatable in vast sections of the world. So it was this kind of body of ideology, of assumptions that dominated the field. And way back in the 90s and 80s, when one talked about mental health problems in a cross-cultural context, it was a highly academic discipline, a discipline that was very heavily influenced by anthropology, and it was all about exploring how cultural factors would influence the phenotype, whether, for example, there were unique cultural syndromes, and I'm sure all of us remember in our own training hearing about conditions like AMOC and the TART syndrome and God knows what else. And so it was almost like an anthropological, a curiosity shop. How do brown and black people in the rest of the world experience mental health problems, almost as if we were watching people in a zoo. Now, this was the challenge we had, and about 25 years later, and here I'll be drawing in this slide, essentially just a set of very distilled lessons that I have drawn from my work initially in Zimbabwe, then for a long period in India, but also mentoring programs in many other countries in both Asia and in sub-Saharan Africa. What do we know about mental health problems in the global, cross-national, cross-cultural context? First, that mental health problems, just like physical health problems, are universal experiences with very similar core features and very similar responses to interventions across populations. That does not mean cultural factors are irrelevant. Far from it. Cultural factors are extremely important, but they're just as important for all healthcare. Equally important is a recognition that mental health problems at their heart are universal health experiences. I can feel psychological pain in different parts of the world, in different contexts, in the same kind of way that people feel physical pain. Second, that mental health is inseparable from one's personal life story, one's physical health, and one's socioeconomic conditions. And in this way, the experience of mental ill health is a very deeply personal one. And as much as we can try to categorize people in the way that DSM and ICD does, the truth of the matter is there's enormous heterogeneity within each of our categories that makes any one-size-fits-all solution or understanding of mental health problems impossible. Related to this, therefore, mental health care must go beyond narrow algorithmic guidelines, but embrace a diversity of perspectives, experiences, and providers. And I'll illustrate some of these points during my talk. And finally, people with a lived experience must be central to all aspects of mental health care, from defining what are the priority outcomes that need to be addressed, to defining the kinds of interventions that should be delivered, and in fact, to be engaged with interventions and holding the system accountable. This is really, in many ways, the major findings of a body of work that can be subsumed under the discipline of global mental health. Global mental health itself is a kind of a hybrid of what used to be called international or cross-cultural psychiatry or psychology and global health. But I would position it much more within the broad discipline of global health, which, as you can see from this definition, is a fairly recent field in and of its own right. And what I've done is I've just inserted mental to indicate what the specificities of global mental health are within the broader discipline of global health. And I've highlighted in red achieving equity for one very important reason. For far too long, when people talked about international health, it was typically a very patronizing conversation about people in wealthy countries, really referring to people in less resource countries. Even global health, to be absolutely blunt, I think by and large, when global health is taught in the US, it is really just simply a renamed version of international health. But actually, I believe global health has enormous relevance in the US, indeed in all countries of the world, because of what I've highlighted here, and that is the issue of equity. And I don't think it needs spelling out to this audience about the massive inequities in mental health, both in terms of the quality of the experience of mental health across populations, but also in the access to preventative and intervention and treatment interventions for mental health problems that are experienced by groups in the overall US population. I don't need spelling out that there are massive inequalities and inequities in all aspects of healthcare, but particularly so in mental health care in the US, and therefore global health is actually local health when it comes to the US. So what are the opportunities? What are the opportunities that the US can learn from? And I think I would like to start with the NIMH's singular contributions to the field that begins with about 10 years ago when it launched the Grand Challenges in Global Mental Health exercise that was co-chaired by Pamela Collins and myself. This was an exercise that the NIMH had launched in response to the other Grand Challenges exercises in global health that had been set up by the Gates Foundation. Those Grand Challenges exercises focus primarily on infectious diseases, and this one was a response of the NIMH to use a similar kind of methodology and language applied to mental health. What did it mean? It simply meant that we were going to try and identify the leading research priorities, which, if addressed with adequate resources, could significantly and within a very limited time contribute to the reduction of the burden of suffering due to a particular set of health problems. Whereas the Gates Foundation Grand Challenges exercise was focused on infectious diseases, not surprisingly, the NIMH exercise was focused on mental health problems. So Pamela Collins and I assembled a group of priority setting group, a Delphi panel really, comprising more than 400 researchers, practitioners, and advocates from around the world. And we asked them this question: can you help us understand what you think are the major priorities that, if addressed with research, could actually reduce the burden of suffering due to mental health problems globally? And in an iterative way, we arrived at a set of priorities that has become the foundation of global mental health research funding. Now, for those of you wondering what those priorities were, interestingly enough, the priorities, none of the top 10 priorities had anything to do with basic science, fundamental science, or discovery. None of the priorities, including, interestingly enough, for the subgroup of neuroscientists who we looked at separately from the overall group of respondents, actually said the priority was to find out what a particular genetic marker for a particular mental health condition was, or what a particular neuroimaging marker was, or what a particular new therapeutic might be. All the leading priorities were simply saying, can we do better with the knowledge we already have, in some instances, knowledge that we've had for up to 50 years and which we've done so poorly in actually disseminating. Based on this set of what we now call implementation science priorities, the NIMH and a number of other funders around the world rallied around these grand challenges. My back of the envelope estimate is that more than $500 million of new research money has now been spent over the last decade, leading to a flourishing not only of science, but also flourishing of research capacity across the world. And it's a real pleasure to see how much capacity building there has been through also very specific capacity building grants, both from the NIMH, but also other major funders like Grand Challenges Canada, the Wellcome Trust, and others. Today, about 10 years on since the Grand Challenges, I think we can really look at the enormous achievements that this field has produced, that my mentor Arthur Kleinman often refers to as perhaps the most exciting developments in psychiatry in the last decade. And in particular, the most exciting development of all has been the demonstration that we can deliver clinical and preventative interventions in contexts even where there are no mental health professionals at all, where there is a very different understanding of mental health problems from what ICD and DSM advocate, where there is no history of mental health care, or where that history has been largely dominated by colonial asylums. We know how to deliver clinical and preventive interventions in an affordable, in an acceptable, and perhaps, of course, most importantly, an effective way. This body of evidence is so large that there are now more than a dozen systematic reviews meta-analyzing the effects of these different task-sharing interventions. And suffice to say that all of them speak to the same overall result, that this kind of approach is highly effective in improving recovery rates from a range of different mental health conditions, but also preventing the onset of mental health conditions. I've played a very active role also in this research agenda, and I've worked primarily in India, but as I said, I've also mentored programs in many other countries, but my primary work has, to be fair, has been really largely conducted in India. And here I've really worked with this small non-governmental organization. It's like a research mental health implementation science organization in India called Sangath. And here you could just see some examples of the of snapshots of papers that Sangath has led. These are all randomized controlled trials published in the world's leading journals, the Lancet mostly, but also PLOS Medicine, JAMA Psychiatry, and others. And what you can see as you quickly scan the titles of all of these papers, what you can see is the broad range of different kinds of mental health goals that these different trials have sought to address, from autism in childhood to school-based interventions to interventions in primary care. And of course, a huge amount of our recent work has been primarily around psychological treatments. So this particular treatment, I'll turn back to it a little later. I'm particularly pleased about this treatment because this is the briefest psychological treatment for severe depression on record, 6 sessions. It is built around the theoretical principle of behavioral activation. But what I'm particularly excited about is that this treatment has now been funded by PCORI to be adapted for use in the US and Canada, really representing a very unique example of how a global health innovation has now come home to the US to improve access to treatments for the most common mental health problem of all. Sangath, of course, is an innovator, and beyond discount sharing, it is now, over the last 5 or 7 years, it's been working on utilizing and leveraging digital innovations in a variety of ways, largely working with my team at Global Mental Health at Harvard, but also with many other collaborators in other parts of the world. So I'll talk a lot more about building the workforce a little later in my lecture, which is about using digital technologies to actually train frontline workers and to assure supervision and quality assurance. This is a new program called Empower, which I will turn to a little later. We've been using digital interventions in a variety of ways. The standard way, of course, is using digital gamified interventions for promoting self-care for young people, for adolescents in school. But we're also using digital innovations in a variety of innovative ways, such as, for example, using games to assess cognitive developments in very young children. And with John Touros launching a new program on using smartphones to assess deep behavioral phenotypes, digital phenotyping people with psychosis, to examine how we can use that to reduce relapse and to improve remote early interventions. Another important way of using the digital media is engaging the public, and particularly proud of a program that one of my young colleagues in Sangath has launched, which is to use social media as a way to actually get young people to open into conversations about mental health, to really focus on mental health as a positive asset, and to really focus on positive stories of recovery. And I think in the next slide, I'll show you a brief video to just illustrate how it works. But in short, it's really about storytelling. And we believe very strongly that stories of the lived experience are profoundly important to change the narrative around mental health.
It's not always easy to talk openly about our mental health, both our struggles and our victories. But when we do, we let others know that they are not alone. Sharing our stories with others can inspire them, offer hope, and help them. Man Mela is a museum about young people's mental health stories from India. We feature stories from different parts of the country that tackle common misconceptions about mental health, highlight common problems, and share information on how to seek help and build resilience. Our storytellers work with a team of researchers, writers, and designers who help bring their stories to life using art and technology, enabling viewers to interact with their worlds as they travel through journeys of finding hope, identity, meaning, and empowerment. Our stories matter, and telling them can make a big difference.
So I think you've probably got a good sense of what I meant by people with a lived experience being at the center through that particular example of telling stories about the lived experience. This large body of evidence, and I want to again re-emphasize, this is a really large body of evidence. We're talking of more than 100 randomized controlled trials and literally thousands of other kinds of studies, ranging from social sciences studies, studies around the lived experience, epidemiological studies, and so on, is completely redefining mental health care in the global context. And in this slide, what I want to do is just give you examples of 4 different ways in which mental health care has been redefined. In the what? 2 examples. First, the example of paring down complex psychosocial interventions, what my colleague Bruce Jorpeter from UCLA and John Weiss from Harvard often call dismantling and distilling. What are the active ingredients of complex psychotherapies, for example, which, when delivered, can produce at least as good as the full Monty effects on clinical outcomes? A very good example of that, of course, is behavioral activation for depression, which is really a component of the broader set of strategies and techniques using CBT, and which now at least 3 head-to-head comparisons with CBT have shown is just as good as CBT in terms of remission rates from depression. So that's very simplified, because you're really stripping away a lot of other components using only one component. And why is that useful? Because it's much easier to learn for a provider. And of course, it's also much easier for a person who is being given psychotherapy to actually practice it. It's much easier to practice one thing and master it than to practice many things and try to figure out what to use when. Another example of the what is that many global mental health interventions are better defined as psychosocial intervention. The reason for that is we all know that most of our patients with mental health problems almost always have a coexisting social difficulty, a social determinant that accompanies the mental health problem. And that in our traditional way of focusing only on the mental health symptoms, we are really simply missing a large part of the overall picture. In most global mental health interventions, recognizing and helping the person navigate and address the social determinants of mental health is an integral part of the overall intervention. The second domain of redefining is the where. Almost no global mental health innovation intervention takes place in a mental health facility, to a large part because there are very few or they don't exist anywhere in most sections of the world. So where do they take place? They take place wherever people with mental health problems are actually visiting. Typically, that would be in primary care centers. They could also be in schools for younger people. And in our own work in India, a lot of our interventions are home delivered, particularly for people with serious mental health problems and developmental disabilities, because oftentimes these are conditions that themselves often come in the way of people being able to come to the clinic. So our logic is really about optimizing acceptability of engagement for people with mental health problems, and recognizing that people with mental health problems often have great difficulty in keeping appointments and coming to the clinic for a variety of economic but also cognitive reasons. And so going to people is the most logical thing to do. And I should say here we're very inspired by global health. This is exactly the same philosophy that people adopt, for example, for expanding access to quality care for HIV/AIDS or any other chronic condition. Go to the patient rather than ask the patient to come to you. The who? Well, the who is pretty much anyone in the community who has a calling to care for others. And in this way, what you really do is you completely change the conversation from saying, oh my God, we don't have enough resources, constantly feeling defeated by the challenge, from that particular narrative, reorganizing or reframing the narrative by saying, well, how do we use the resources that we already have? How do we use the resources that every community has, no matter where you are in the world, to become involved with mental health care? And so a lot of the work that I do is with lay people, but most commonly, of course, the scalability of these sorts of interventions really relies on community health workers, teachers, nurses, a variety of non-specialist providers, and that might vary from context to context, and particular kinds of mental health issues that might vary from one sector to another. But essentially, it could be anyone, and then it comes to the final and most important domain of how is obviously we're not training these individuals to become mental health professionals. We're really training them to deliver very specific evidence-based interventions, and that requires training that is very competency focused, followed by a scaffolding that supports and supervises these providers, but also provides a referral pathway to more specialized providers. So what we're doing here is not replacing specialized services, but expanding the footprint of mental health care beyond the clinic where specialists operate. This evidence is transforming mental health globally. And here I show you three different documents that represent major policy instruments of the World Health Organization, the World Health Organization's independent high-level commission on NCDs, non-communicable diseases, on which I served, which for the first time was the first time actually that the NCD community has embraced mental health alongside the usual other NCDs, such as, for example, diabetes and cancer. And then finally, the World Bank Disease Control Priorities Program on the right-hand side. Now, 10 years ago, if I had to look at the equivalents of these sorts of policy documents 10 years ago, you can be sure that there would have been no mention of the use of community health workers or task sharing more generally in conversations about mental health. In fact, mostly mental health wouldn't even have been acknowledged in these sorts of documents. Today, these are front and center, the most important recommendations that all of these global policy instruments are calling for. And of course, this is thanks to the very large body of implementation science that has emerged over the last 10 to 15 years. I want to now turn to why this evidence is so very important by thinking about the threats to mental health. And I'm going to focus mostly here in America. Let's just start by looking at how successful we've been in both developing countries, but also in wealthy countries in assuring coverage of minimally effective care for the three leading mental health conditions that I show on this slide: anxiety, mood disorders, and substance use disorders. These are on the basis of meta-analyses of large numbers of surveys, and obviously, therefore, these are aggregate or average rates. What you can see here is more than 95% of people with one of these three conditions had not received minimally effective treatments in low and middle income countries. This must surely reflect perhaps the highest unmet needs for care for any health condition in the world. Now, before I show you the high-income countries, let me just give some context. High-income countries like the US or Western Europe spend 1,000 times more on mental health care and have 1,000 times more resources, whether it's psychiatrists per capita, psychologists per capita, inpatient beds, dollars spent per capita. In whatever metric you choose, high-income countries spend vastly greater sums per capita than low and middle-income countries. And you would like to see, therefore, some impact, at least on coverage. Of course, you do see much higher levels of coverage, but I think this is still far from adequate or satisfactory. If it is the case that more than 70% of people with these conditions in low and in high-income countries do not receive minimally effective treatments, we have to ask ourselves questions about, is the current system adequate or sufficient? And is it only the case that we simply need more money for business as usual, or do we need to reimagine business as usual altogether if we are going to change these rates? Of course, these are images you do not see anymore. The previous slide showed you what care looks like for mood, anxiety, and substance use conditions. This is what care looks like for people with serious mental illness. These are actually images taken in the last 10 years of mental hospitals in Eastern Europe, India, Indonesia, and Chad. And as you can see, these are horrific images, as I said, probably not seen in the US for a long time, but continue to be really a blot on the landscape of mental health care in the global context, something which Arthur Kleinman has described as a fundamental failure of humanity. While it's reassuring that we don't see images like this in the US, it's important to remember that a lot of stigma and discrimination against people with mental health problems, and indeed against mental health professionals, really comes from these sorts of places. We often think of stigma and discrimination simply as something to do with people's false beliefs, but actually these are not necessarily false beliefs. These are actually beliefs based on the reality of what mental health care has historically looked like. And it's not just the conditions of these hospitals that are important. Let's not forget that mental health care is the only kind of healthcare which actually could involve you being carted off by the police in a police van. You never would associate that, for example, with care for cancer or hypertension. While it's true that we don't see these kinds of images of mental health care in the US, we have, in many ways, people would argue, we've simply replaced the bars of the hospital with the bars of a prison. And I'm sure this particular statistic is very familiar to many of you in the audience. But what should really worry us, I think, is the worsening that we have seen in recent years. These are data from the SPRC, and they really are quite staggering. They suggest that in the last decade, suicide rates in the US have been rising across all age groups. But the highlighted box tells you where the real burden of suicide is in terms of the increasing rates in the last decade. Nearly a 50% increase in young Americans. I can't think of any other health condition, actually, which has shown such an incredible rise in the last 10 years. And if you have to think about, supposing I had to change the slide from suicide rates to breast cancer mortality rates, you would imagine that this kind of figure would send alarm bells across Congress. But it is interesting how much under the radar this particular figure has been. I mean, there are certainly conversations happening about it, but certainly I don't think proportionate to this staggering increase that we see in what many people would consider is the demographic dividend of any society, its young people. I should point out that this is not only happening in the US, but it's also trends that we see in other wealthy countries. Over the same period of time, you can see dramatic increases in suicide mortality rates in England and in Australia. I've chosen wealthy countries because these are the countries for which we have the most robust and reliable suicide mortality data that is also temporal. So we can really look at changes over time. And you can see 50 to nearly 100% increases in youth mortality rates due to suicide in these two countries. This was before the pandemic. What's happening during the pandemic? The latest data, and obviously the pandemic is still on us, and clearly it will be premature for us to say that we have the final understanding of the impact of the pandemic. We probably will not have a final understanding for years to come. But let's look at the data that we currently have. And this comes from the MMWR from June, a little earlier this year. And what I want to show you is the CDC data on from over 5,000 adults in the population, in the general population, on the prevalence of anxiety and depressive disorder, and then the prevalence of significant suicidal thinking in the prior 30 days. And I'm going to first show you the results for the whole population and for young people. And again, staggering numbers really, but look at the numbers that you see here for young Americans. 60% plus rates of anxiety or depressive disorder. This is based on validated screening questionnaires like the PHQ-9. And nearly a quarter of young Americans have seriously contemplated suicide in the past 30 days. So what I showed you in the previous slide was bad enough, but it's actually getting a lot worse as we speak, thanks to the pandemic. If we look at historically disadvantaged groups in the population, very similar figures as the general population, perhaps a slight elevation for some of these disadvantaged groups. And if we look at those who are in the population, the people with the least education less than a high school diploma, as we've often seen with the social determinants of mental health literature, you'll see also much higher rates than in the general population. I'm going to pause for you to just look at this slide and just absorb these numbers. 2/3 of the young Americans in this MMWR survey met clinical criteria for depression or anxiety disorders, and a quarter of them had seriously contemplated suicide in the last 30 days. This is the current burden of mental health problems that we face. And if Angus Deaton, the Nobel Prize winning economist down the road from where you are now in Princeton, and his colleague Ann Case are accurate in their description of what led to the falling life expectancy and increased premature mortality in working class, predominantly white Americans in the Midwest following the financial crisis of 2008, in their fantastic book, Deaths of Despair. It's interesting, their selection of words is really important. As opposed to deaths of hunger or poverty, it's deaths due to losing hope, losing a sense of purpose for one's own life. If this is in fact going to happen now, then it is going to be a much worse epidemic of deaths for a couple of reasons. First of all, because this is not simply an American economic crisis. The financial crisis to a large extent was very much an American crisis, and the rest of the world's economy was largely protected because financial regulation was much better in most other countries, and so the rest of the global economy was able to pull the US up with it, and therefore it was a much shorter crisis. This time around, almost every country in the world has been affected. The second reason, of course, is, as the World Bank president has pointed out, that already hundreds of millions of people have been driven into poverty. I use the word extreme poverty here because the World Bank definition is $1 a day. And I think all of us who live in the US know that that is an extreme definition of poverty. That if we look at relative poverty, that is to say, having less resources now than one had last year. In fact, the numbers of people around the world who will be driven into poverty is going to be far, far greater than 100 million. By some estimates, about 500 million to 1 billion people around the world will be affected, and a large number of those are going to be here in the US. So I want to end by thinking about how we can square, as it were, the circle here, the circle that we do know how to deliver mental health care in low resource settings. The US is one of the best resource settings in the world, but yet has relatively poor coverage of quality mental health care, and there are enormous disparities in access to quality mental health care. How can we actually find ways to really bring some of these global mental health innovations back home to the US? Well, some years ago, the editor of The Lancet, Richard Horton, invited me to lead a commission for the journal on thinking about how this dramatic evidence from global mental health can transform the narrative on mental health care globally, and particularly in the context of the United Nations Sustainable Development Goals. I'm not going to go into any details about our major findings, but I'm only going to summarize some of the key messages, which I think are already evident from my remarks, but I'm going to distill them in this one slide. What are the key messages that we recommended? There were 28 of us together who formed the commission. And the key messages can be summarized on this slide. Firstly, that we must look beyond the binary. We must look beyond the binary, not only because it is not reflected in the neuroscience of mental health problems, In fact, as my colleagues who do clinical practice in America, I don't, really would say over a quiet moment that actually these binaries are largely driven by the insurance industry. And if we are really going to be science-grounded practitioners, we must look beyond the binaries. We must look at the dimensional nature of mental health, because that opens the door not only to greater acceptability of conversations around mental health problems in our population, but also it opens the doors to thinking about approaches across the dimension of mental health that also privilege prevention, which particularly targets the structural and social determinants across the life course. And I want to emphasize the early life course in childhood and adolescence. It's particularly important periods of brain development when environments are critically important. A rights-based approach to eliminating coercion and institutionalization in mental health care. I'm very passionate about this. I know this is a very divisive issue, but I think as a profession, we must take a position that any form of coercion and involuntary treatment is something that we must work collectively towards eliminating altogether in the near future. And in fact, there are many different strategies that the Lancet Commission speaks about that are evidence-based, that demonstrate how we can dramatically reduce coercion in mental health care. And of course, at the base of the pyramid, building the foundations for the task sharing of psychosocial interventions, which we believe will greatly enhance the overall quality of care and increase the coverage rates of minimally effective treatment that I showed you earlier. This is really the goal of the Empower initiative that I want to end my grand round with. This is an initiative of global mental health at Harvard, which is a cross-university initiative that we launched a couple of years ago to really put into practice some of the major recommendations of the Lancet Commission. And one of them was, of course, the scaling up of quality-assured psychological treatments, particularly by building the workforce at the base of the pyramid of mental health care, which is really in the community. So if we think about some other conversations around digital solutions for mental health care, let's look back in time and remember that actually the West Coast, the tech industry has been thinking about this for a long time. But their way of thinking about this has been to replace the provider altogether. Because providers were so few, so scarce, so expensive, their approach has been to take some of these evidence-based psychological treatments and convert those into apps that people with mental health problems could actually practice themselves. As it were, there is no need for the provider at all. Thousands of apps later, we now know that actually the vast majority of them have had no takers. If you look at the actual user rates for these apps, you will find that 98% of people log in only once. And I think what this tells you is something very important and intuitive for anyone who's done psychotherapy or mental health care, that actually when people are suffering from mental health problems, what they want is not to sit with their phone to figure out how to fix their own minds, but they want someone who they can trust. They want a skilled human provider, even if that human provider is delivering care on a telemedicine platform, at least it's a real person, as opposed to sitting with an app and trying to figure out what to do. And I think that's what Empower is seeking to do, is to build the workforce that can deliver mental health interventions, particularly psychological treatments, at the coalface. It's not a new technology platform, but in fact, what it is a novel way of linking established technology components into one continuum. On the left-hand side, you can see, for example, the use of massive open online course technologies, but combining that with competency-based learning frameworks that allow you to move from an evidence-based manual through a blueprinting process to create engaging online content, digital content that a learner can actually navigate on their own with remote coaching if needed, followed by validated competency assessments. We all know that simply doing an online course is completely insufficient to master a psychological or mental health intervention. And so this is followed then by a set of digital tools that enable those learners who've completed competency assessment to start doing case-based learning with supervision and using, very importantly, quantifiable quality metrics that can help the learner actually measure how well they're delivering care, but also allow the system and the supervisor to see how individual learners are actually mastering care. And once they've mastered care, the same platforms or components can be used to actually support quality assurance indefinitely. And then finally, as larger numbers of providers are actually delivering care, to use aggregated data from multiple providers to do things like, for example, evaluate the impact of the program at scale. But I think the other interesting thing is also prediction models. So you can imagine if you have thousands of sessions from hundreds of providers that have been quantified in terms of the quality coding of metrics, and these are then linked to EHR data, that you can begin to see how you can have data science being used to actually define or to identify which specific quality metrics of the psychological treatment, the black box of psychotherapy, best predict outcomes. And then you can use that in feedback loops to focus the supervision and training more and more on those specific components of the psychological therapy package. We've been at this now for a few years, thanks to NIH and Wellcome Trust support. We started, as I mentioned to you earlier, with the brief BA treatment for depression. Initially, with NIH support, we have just completed the digitization of the learning of the treatment and are conducting a large randomized control trial comparing digital learning, coach-supported digital learning, with the orthodox gold standard workshop-based learning delivered by experts. And remember, this is the barrier we're trying to address with this, is that the historic approach to training providers to deliver psychotherapy is 100 years old, really. Is bringing providers in, into a classroom in a leading sort of academic center, and having a leading, the therapist, who is oftentimes the person who's developed the intervention, doing the training. This is impossible to scale up. It's been impossible to scale up in the US, and it's definitely impossible to scale up anywhere outside the US, simply because we're talking of volumes of providers who need training, and also the cost, both in terms of time as well as in terms of the cost of the experts that you need. So this is what the app looks like. It's obviously on a smartphone, because this is the most commonly used device. Importantly, in India, because internet connections are very unreliable, actually the entire learning content can also be delivered offline by downloading the entire curriculum offline. Our immediate plans and priorities are to take this depression treatment, to adapt it for the US. We're really delighted that, thanks to support from philanthropists in the US, we are now actually doing training of, we're developing the US adapted content. And I'm also delighted to acknowledge the important role of the American Psychological Association. I say this because you can imagine that there might be pushback from the guilds if they say, well, you're going to deliver BA through non-specialists, so that's not acceptable. Well, the APA has completely embraced the idea, and the APA actually now is a full partner of the Empower initiative, and it's particularly looking at the suitability of the curriculum that we'd initially developed in India and adapting it for delivery in the US. And of course, we have a whole team of scripters and so on. And of course, this is also an iterative process where we work directly with frontline providers. Where in the US, I'm sure many of you are thinking, in Texas with the Meadows Mental Health Policy Institute, which I hope is only the first of what is going to be a much larger group of implementation partners that we will engage with. I mentioned the Pakori grant. The Pakori grant that I mentioned earlier is the adaptation of this BA approach. And I should also acknowledge, very importantly, the role of Sona Dimijan, one of the key architects of behavioral activation, who has been involved with this work right over the last 10 years, initially in India, and now adapting this also for use for peer delivery and for maternal depression in the US and Canada. This is a Pakori grant that is taking this as a resource manual and adapting it for mothers with depression and delivering it with nurses and by telemedicine in 3 sites, in Chicago, in Chapel Hill, and in Toronto. And this entire program is led by Daisy Singla from the University of Toronto. We're also looking to adapt the Thinking Healthy program, which is another brief psychological treatment for depression, but we're probably going to adapt that, really focusing on behavioral activation with additional components that are specific to maternal mental health. And because of COVID-19, we're now working with the World Health Organization and the Wellbeing Trust in the US to adapt interventions that can go directly to the community, both for self-care in the form of a guided self-care model, but very importantly also for community change agents to actually deliver mental health promotion interventions in the broader community. This is not in the clinical context, but much more, if you remember, in the dimensional context. These are interventions that are much better thought through as selective prevention interventions for people at high risk, such as, for example, frontline workers, people who've lost their jobs, and so on. What this means is, in the Empower way of thinking about things, is that you can move from a naive learner, let's say, for example, a community health worker who's never done mental health, complete an online course and complete their competency assessments and therefore become a competent learner, then complete case-based learning and achieve credentialing so that becomes a competent provider. And then finally, over time, after completing a large amount of, a significant amount of clinical work in the real world, then becomes an expert who can then, of course, feed back and become a coach for those who are beginning the process. And you can see, therefore, there's an inbuilt system here of sustainability, and so that we ultimately rely less and less on very expensive experts, because expertise is drawn by experience as people make their way through this particular pathway. The impact, well, I think we can all see there is a rising demand. There was a rising demand over the last decade, and there will be an even greater demand in the years ahead. And if we stick with the current system, where we have really failed to a large extent to address the demand that existed even before the pandemic, we're not going to actually go beyond the tip of the iceberg. What we really need is a massive increase in the availability of skilled providers who are working in a collaborative and a coordinated way with the rest of the mental health care system. And that is really what Empower is seeking to do, so that we can massively increase the numbers of people who are helped and at the same time assure that those who need more specialized help can actually get it quickly. In the end, what I hope that this body of global mental health evidence is enabling us to do is to reframe mental health well beyond a narrow biomedical disease-focused kind of issue, but as a universal human quality that is important to everyone, to all people at all times in their life. It's indivisible from other aspects of our health, and it is particularly important to young people. And of course, it's never been as important as now. And therefore, if we have to invest in mental health, and let's be clear, this is truly a historic opportunity. On Saturday, the World Health Organization celebrated World Mental Health Day, and the theme this year was that we need more investment. Yes, we absolutely need more money. There is no question about that. But I would suggest that we need to also spend it wisely. And to do that, we need to be guided by the best science of cost effectiveness. How do we deliver quality mental health care to the greatest number of people at the least cost? And alongside that, I would greatly support the idea that all mental health care must be grounded in a human rights approach that respects the dignity of the person whom we're serving. And to do that, mental health care must embrace a much greater diversity of experiences and strategies which work, because that is the only way we can really realize the aspiration captured on this slide, that everyone, everywhere has access to effective mental health care. Thank you.
Thank you so much, Dr. Patel. That was a really beautiful presentation, really not only covering the complex and broad global mental health challenges that we have to address, but also taking a really solution-oriented approach to really give us a sense of some of the potential paths forward to address these issues. So really thank you. And also as a child psychiatrist, I very much appreciate your emphasis on adolescents and young adults, and couldn't agree more. So I guess I'll get us started with one question. So in one of the initial slides that you presented, you talked about one of the barriers in global mental health being the perception or perhaps the misperception that there are more pressing medical issues at play, and those need to be addressed first before we can tackle mental health concerns. And I guess that got me thinking about the risk of COVID, bringing that issue up again, and that COVID needs to first be addressed before we can tackle mental health issues. And I'd be curious to get your thoughts on that.
This is a real constant tension, Jonathan. And my way of dealing with this is to really say that if we're providing person-centered care within the context of universal health coverage, which is, something which of course is politically controversial in this country, but actually it's not politically controversial anywhere else. I think almost every other country in the world embraces the idea of universal health coverage and sees it as an entitlement for all the citizens of that country. But so if I look in the global context, the way I really position the conversations around mental health is within the context of universal health coverage, which says that all health problems, all health conditions for all people must be addressed. Obviously, then I think all of us have all the other arguments, that mental health and physical health are not separate. Maybe they feel separate in the way that historically biomedicine has addressed it, but not in the person-centered care approach, in which really we must address these simultaneously because they feed off each other. And we know countless examples of how that happens. In the context of COVID-19 in particular, since you raised this, I think it is very, very, again, first of all, I say it's very sad that the whole thing has become so politicized. The issue of school closure, let's take that as perhaps something that has been very much in the forefront of all of our thinking. It's interesting that when we think about school closure, we don't simultaneously ask questions about the impact of school closure on mental health and development of children and young people. It's only seen through the lens of reducing risk of transmission. While I think that is a very important thing to think about from a COVID-19 perspective, I think there is a missing point here, which is that schools do far more than simply be places to transmit infections. And I think it's also doing a disservice to school environments as being seen purely as places where you go to learn science and geography, because actually schools are far more than that. That is actually an environment where young people actually socialize, where children play. And if we're really thinking about mental health as being part of the conversation, those of us who are in the child mental health space should be asking important questions about the role of schools that go beyond just simply being learning environments. So I think it's not to say that we should discount the risk of schools in terms of the risk of COVID-19. I just wish we had a more balanced conversation that was going on here, about balancing the mental health needs of children and young people and the kinds of policies that we are embracing to try and address the COVID-19 pandemic. And unfortunately, I don't really see that in most countries.
Yeah, I could not agree more. Another question that's come up in the chat function is, you brought up the work of Angus Deaton in Deaths of Despair, which on the one hand really suggest very complex societal and economic pressures which are giving a rise to presumably to mental illness, and yet on the other hand, you also rightly emphasize the importance of trying to simplify our interventions to really achieve sustainability and scalability. Is there some tension between those two drivers, the complexity and also the drive to simplify?
Yeah, there is definitely there is a huge tension. I completely acknowledge that. There are two levels of tension. The first level of tension is where do you act? Let's be quite clear. Professor Deaton's work and Anne Case's work doesn't talk about mental health care at all. It's an economist's view of the deaths of despair, not a physician's view. And I think therefore their policy recommendations are all around issues like inequality. And certainly if you look at the economist's view of well-being, there's in fact at Columbia University, the work of Jeff Sachs and others in the World Happiness Report. If you look at that particular conceptualization of population well-being and mental health, the perspective is entirely addressing the social and structural determinants of mental ill health. And so, what I would see is the first tension is between individual or group level interventions that people in our community are much more accustomed to delivering versus those that are political, structural, and social interventions. And my response to that is we must never make this an either or choice. In the very same way that when we were addressing HIV/AIDS, we never said that should we be championing the rights of sexual minorities and sex workers, or should we be providing antiretroviral drugs? No, I don't think it was ever that choice. And I don't think we in the mental health field should be, should fall prey to those sorts of questions. We should be confident and comfortable that it's not either or, it's both. And that there are multiple sectors that need to respond in order to address the rising tide of mental health problems. Let's be quite clear for young people, for example, a lot of the mental health problems lie in toxic peer environments. I'm sure many of you are familiar with the college survey on the 21 schools that were surveyed on sexual violence in American campuses. I mean, shocking figures. About a quarter of graduate, undergraduate women, young women in these 21 campuses, which represented both private and public institutions, 25% reported non-consensual physical sexual violence. I mean, this is unbelievable. And so no amount of psychotherapy is going to solve that, okay? But at the same time, I don't think we should ignore the fact that those women who have suffered violence also need mental health care, while we also do things to combat the structural factors. Let me turn to the second tension. The second tension is between the contrast between person-centeredness, which means that your mental health intervention has to be totally tailored to that person's individual life story, their personality, their childhood experience, is something that an analyst would feel completely at home with. And scalability. There is an obvious tension there, right? I mean, on the one hand, you've got this incredibly individual focused approach, which many of my colleagues in this audience feel completely comfortable with. And on the other hand, you've got this algorithmic approach, you diagnose depression and you deliver care. I think this is still a tension that needs to be navigated. And to be honest, Jonathan, it's important for us not to take positions on this, but to see these as being complementarities that we must navigate. There is no question we need scalability, and there is no question that when you scale up, you naturally have to simplify and you have to standardize, because that's also what quality assurance relies on. But there's also no question that one size does not fit all in the mental health field. We cannot adopt a malaria or TB approach in our discipline, because, I often give that analogy with TB and malaria. It doesn't matter who you live with. It doesn't matter what your childhood was like. It doesn't matter what your personality is like. If you got TB, you get exactly the same prescription. And I think we obviously must acknowledge that the mental health field does not work in the same way. How we find the right balance is an implementation question that is still work in progress, but we need to acknowledge that tension in all our thinking.
Thank you. That's a really helpful way to frame the issue and to be thinking about it. So there were some questions about the Empower platform. I'm going to run through a few of them. One is, can you talk a bit about which countries have that platform available? How emergency services are addressed, so if someone needs urgent intervention. And then there's also a question specifically about implementation in South America.
Yeah, so just to say, Empower is only about a year old, of which about 6 months have been gobbled up by the pandemic. And so, the country is only India and the US at the moment, and that's where we're going to stay. Why? Because I spend my time in both countries. Both of them are my homes. And so I have a chance to really provide some oversight as my teams in both countries are rolling this out. In the US, we are focusing on the interventions I already told you about, and in India as well, the same interventions. I just want to clarify, Empower is not generating new interventions, it's scaling up existing and evidence-based interventions. So we basically select interventions. We have a science council, wonderful Professor Weissman from your community actually serves on that council. And so the idea really is that the council, as it was, signs off the intervention for scaling up. And then that intervention goes through a systematic process of blueprinting and digitization, iteratively testing. So currently, we're only working in one site in the US and Texas. And we're working in 2 states in India. I'm hoping very much that, this is a learning process for us, right? We don't actually know exactly what challenges we're going to face, because this is also pretty audacious, the idea that we can go to scale using digital platforms for training workers in these 2 countries simultaneously. And so we're doing it one step at a time, recognizing there are going to be, unknown, unexpected, pushbacks and barriers, so that we iteratively, identify those barriers, we figure out how to navigate them, and constantly are improving our strategies. A year from now, I'm hoping very much that what we will have is very confirmed lessons on how we can scale up a depression treatment in the US and India, but also have begun work on a number of other treatments. Some of the ones that we're really working with are one to do with trauma, and the other one to do with self-care that I already mentioned, for a guided self-help intervention. To the point on South America, well, we don't have any current plans in South America, and that's primarily because Harvard doesn't actually operate anywhere outside Boston. And so our mandate is we have to have an implementer who's interested to work with us. And so in India and in Texas, we do. And if there was an implementer anywhere in the world who was interested to scale up for now, either self-help or depression interventions, they should just contact us and we get into a conversation. We have a very standard conversation about the implementer's role and Harvard's role. We are not employing community health workers. That is the role of the implementer. The implementer has to make sure that all the regulatory and local approvals are in place, etc. We are supporting the implementer with content and with technical guidance. And so that's a very important thing to clarify as well. It isn't for us to choose where we work, it's for the implementer to decide that they want to work with us.
Great. From the list of questions that have come up, it's very clear that there's a real hunger to roll out the Empower platform more broadly. So I hope some people do reach out to you in your group to talk more about that. But at the same time, very much appreciate your measured and paced approach to rolling it out. Was also hoping to hear a bit more about any barriers with licensing agencies and professional organizations. You talked a bit about that in regards to the APA, but it was somewhat surprising to hear that actually has not been so much of an issue. That one would wonder that professional organizations might have the natural inclination to want to sort of protect their turf. And so I was hoping you could talk a bit more about how you've approached that and how you've prevented that from being a barrier.
Yeah, well, that's a good question, Jonathan. It's a couple of things to say. First of all, the APA's CEO, Arthur Evans, is a champion of global mental health. That helps. That helps a lot. I think the APA's position is simply this: psychological science has never been more relevant as it has been in the last 6 months. And that if the American Psychological Association does not see its primary purpose of improving the health of all Americans through the dissemination of psychological science, then it will lose this historic opportunity to be relevant to America. And so it is a very conscious move that the APA is making. It had happened, I think, the pandemic has really been a very important driver. And that's why I say it is a historic opportunity for everyone to sit back and rethink what mental health care should look like. And Arthur's leadership role in the APA is extremely central here. Without his leadership, I don't think we would have actually we would arrive where we are today. So that's the first thing to say. The second thing to say is I work with some of the America's leading clinical psychologists, like Steve Holland, for example, but there are many others, Terry Wilson, Alan Kasdan. So these are like household names in the field of clinical psychology. And when they endorse and embrace this idea, it has an impact. It has an impact on clinical psychologists all over the country when the gurus of the field say, hey, you know what, we've got to do this. The third is that I'm always explicitly saying we're not training psychologists. We're absolutely not. There is no way one can achieve the kind of skill set that mental health professionals have with this kind of approach. It's impossible. This is a little bit equivalent. I'll give you the example so that it becomes clearer. It's a little bit equivalent, for example, to training a peer support workers to be a good befriender for people with for chronic psychosis. That doesn't make them a psychiatrist. Yeah. What it does is it helps people in the community offer interventions that psychiatrists may never provide, may not have the time to provide, they may not have the inclination to provide, and they may not even be acceptable by the person who's receiving the intervention. So this is not instead of, this is in addition to. And in some respects, when you ask the question about how do we work, how do we get past regulatory approvals, we are very clear we will only work with implementers who are guaranteeing access to more specialized mental health behavioral services, so that the frontline providers are not working in a vacuum. What they're doing is they're working in a collaborative care system in which people who are being referred to them are being assessed and can be red flagged as needed to actually seeing a more specialized provider. So there is a real scaffolding, there's a security here, there's a safety net here. These are not people who are working without full support and supervision of the more specialized healthcare system. I'm sure we're going to learn more as we roll out, Jonathan. I won't pretend for a moment that this is something that we've anticipated every possible potential risk. But I think we've tried to anticipate as much as we can. But ultimately, the proof of the pudding is going to be as we start rolling out and seeing the sorts of things that emerge, being able to then identify those risks and mitigate them as we go forward.
So this next question is a tough one. So be prepared. As we take social determinants of health seriously, specifically poverty and its impact on mental health, how do we approach prevention, specifically in low and middle income countries?
So, I think for me, again, this goes back to the conversation we had a little earlier about, where do we position ourselves? Do we position ourselves at the structural and social determinants and or at the end of mental health care? And so I hope we're past that idea that it's got to be either or, that is both. Now, specifically referring to the structural determinants, even there are many levels that you could work at, right? So you could work at the highest level, which is creating a more just, fairer world, which is something that all of us will, I think, most of us, I'm sure, consider a very important goal for human society, but also way outside, our bandwidth. So what can we do in the real world is mitigate or reduce some of the harmful effects of poverty that have a relevance to mental health. And one very good example of that is through supporting parents who live in poverty with very young children with parenting interventions. We all know that early life experiences are probably what I call them is the equivalent to mental health as tobacco is to physical health. If there is one clearly demonstrated risk factor, which is also agnostic of which mental health problem we're talking about, and which has been demonstrated across every context and culture in the world, is adversities in early childhood. And by adversities, we don't talk only about the extreme forms that people often think about, like sexual violence, but actually just box standard poverty, living in a home where parents are struggling to provide the nurturing, responsive, playful, stimulating environments that we know are essential for early childhood development, because they're struggling with poverty, they're struggling with conflict at home. Some of them are struggling with mental illness. So I think what I would do as a mental health professional is advocate strongly for an equity-sensitive intervention in the community to support low-income parents, so that the early years, the start in life that the next generation has, is as good as is possible. And that also can extend to early childhood education environments, preschools, for example, making sure that disparities that exist between wealthier neighborhoods and low-income neighborhoods is minimized through proactive interventions that raise the bar for schools and home environments in low-income neighborhoods. There are many more examples, Jonathan. If there are no other questions, I'll just give one more example, which is to do with conditional cash transfers. I'll tell you, I don't want to preempt the publication of this incredible piece of work that's come from my mentee in Brazil. Brazil has had a conditional cash transfer scheme that was started by President Lula more than 20 years ago, and it's essentially, it's like a benefit, a cash benefit. And it's given to people who are earning below a certain threshold that the Brazilian government has set, but that threshold covers more than 150 million people, and so it's a huge section of Brazil's population that benefits from this Bolsa Familia. the data that we have over the last decade is absolutely staggering in terms of the impact of the conditional cash transfer in reducing suicide mortality, homicide mortality, and particularly amongst Black Brazilians in the last decade. So these are going to be, I think, tremendously game-changing papers that are currently under review. But I think the important point I want to stress is that that is another example of an intervention that is tractable, that you can imagine happening rather than just a kind of idealistic one, let's eradicate poverty or reduce income inequality. Well, let's, for now, really lobby our government to actually provide cash support, direct cash support to low-income families. And of course, right now seems to be a very, very important time for us to be calling for that.
Yeah, I'm glad you brought that up. I was talking with a colleague at Columbia just the other day, Cristiane Duarte, who was telling me about how that program has been scaled up in the context of COVID, and it will be interesting to see whether that mitigates some of the negative fallout from the pandemic. One last question comes from Jean Marie Bradford, and she was interested in hearing about the work that you're doing potentially with government agencies to ensure or to help ensure that the implementation and interventions continue after research support potentially ends.
This has always been a huge challenge, Jonathan, for those of us who are implementation researchers. What do you do after your project is over? And, obviously, the truth of the matter is the overwhelming majority of implementation science projects end with nothing. There's nothing beyond that. People who fund us will say that's not our goal. We're scientists. Our job is to generate new knowledge. So what are the things that I have done that try and address this? I refuse to accept that it's not our responsibility. That we just generate knowledge and walk away to the next project. I refuse to accept that that is a legitimate position these days. It used to be how science operated for a long, long time. But it's interesting when we think about the conversations around the COVID-19 vaccine, that there is this enormous scientific enterprise, but all of it is being tied with funding commitments to actually scale up the vaccine. All of it is tied up with conversations of how the vaccine will be transported to remote sections of the country and the world. So I do believe that this is setting a very good example for us. That science cannot operate in a vacuum, and we do have to think about the implementation of what we've done, and particularly in our field. To be honest, we've done really badly. We've had the science of CBTs like, I don't know, 35 years old, IPTs, I don't know, 25 or 30 years old. How successful have we been in scaling these up? I don't think we've done well at all. So a few things that I do is, first of all, building capacity. To me, this is crucially important. And by capacity, I don't mean just research capacity. That's, of course, important. But thinking about building capacity in the system to deliver intervention. And, of course, Empower is a reflection of my commitment for that. The second is always working from the very beginning, or as soon as you can, with policymakers, decision makers, to ensure that the questions you're addressing are actually relevant to them. They're not just, obviously, you've got to find that right sweet spot, that it's a question that's important for science, but it's also a question that's important for the decision maker who's going to have to pay for whatever it is that your science discovers. The third important constituency that I work with is people with a lived experience, my target group. That's not always people with a lived experience. It could be, of course, parents of young children in a preventative context, but always work with your target group because they're voters. These are people who actually are going to be far more powerful advocates for your research knowledge than you can ever be. We're always going to be seen as self-serving. That we're conflicted because obviously we're asking for more money for basically ourselves. But it is when people who are the ultimate beneficiaries, and that could include frontline workers, primary care physicians, but of course, ultimately people in the community who we seek to serve, if they actually join you, or in fact are the front of calling for their lawmakers, their representatives, to actually finance this particular program or intervention to scale, that's far more likely to work than if people who are mental health professionals call for it. So three important different groups that I work with in all my strategies to ensure that the science doesn't just stay lost in journal pages.
Yeah, our speaker last week was Milton Wainberg, and it was one of the points that he really stressed, which is echoing your point, is that we really need to be thinking about capacity building and sustainability from the get-go, and it can't be at a latter stage of the program. So it's nice to hear you reiterate and emphasize those points. So I think those are all the questions that we had. So again, really want to thank you for taking the time and giving us such an inspiring talk and so many lessons for us to learn from you and your work. So thank you again, and want to invite everyone to rejoin us again in 1 week. And with that, I will say farewell. Thanks so much.
Thank you, Jonathan, and thank you all. Bye-bye.